and then it's going to back up into the lungs. Then you're going to have fluid filling the lungs. Okay? That's a problem. The other side of it is dysrhythmia. You're going to have some irregular contractions or premature contractions. You may have a fast heart rate initially, then a slow heart rate, and then VTach and ultimately VFib. And what's going to happen there is VTach is a heart rate anywhere above 150 to 200, and it's wide complex on the EKG, and that means that the ventricle is just in a last-ditch effort to try to survive. Nowhere else in the heart is working at that point. Okay. And they may have VTach with a pulse. I've actually seen a patient, several, sitting there talking to me in VTach. It's the scariest thing in the world because you know this patient's about to go meet the Lord. And you're like trying to do everything you can to keep it from happening. Okay? Not that you don't want to meet Jesus, but you can. Right? So, what we're going to do, again, during VFib, ventricular fibrillation, no blood is being pumped through the body. It literally is quivering, and it's quivering between 300 and 600 times a minute. Again, you're flushing the toilet so fast, nothing can move, right? Okay. The way that we restore this is defibrillation, okay? We don't like to use the word shock anymore. Shock is a term that we use for, like, types of shock. You can shock somebody, but to shock somebody, you're either going to do one of two things. You're either going to defibrillate them or you're going to cardiovert them. Okay? So when the machine says shock advised, what we're actually doing is defibrillating. Okay? And I want us to get into the habit of terminology. It saves lives because what that does is if they're in VTach or VFib, ventricular tachycardia, ventricular fibrillation, it gives a quick thump to the heart and says, get right, try to set it back in order. For each minute that the defibrillator is not put onto that patient, their chance of survival decreases by 10%.
That's a lot.
Yeah, that's huge. So if you think about that, that patient, for every minute that that defibrillator is not there, 90, 80, 70, 60, And then asystole is what you see on Grey's Anatomy where they're flatlined. Okay? This means the heart is doing nothing. This means that they've been ischemic or without oxygen for a very long period of time. And about 75% of patients that are in asystole will die. Okay? We've gotten them back from there. A lot of people have. But typically, this is somebody who's been down for a while. Okay?
And normally, if you do get them back after systole,
You're not getting a lot back.
yeah.
Cardiogenic shock. Any questions about any of that? No? Okay. Cardiogenic shock is a lot of times caused by a heart attack. Okay? Your body tissues aren't getting enough oxygen, causing your organs to malfunction. So the heart lacks enough force to pump blood. That's a big deal. It's more common in AMI, affecting the inferior and posterior regions of the left ventricle. So the bottom left side of the heart, okay, or the bottom back of the heart is the area that's affected usually. And it's important to recognize shock in its early stages. What also is happening is the heart lacks the power to pump. So we have to determine, is this a pump problem, a pipes problem, or a fluid problem? Okay? Is it a pump problem? In this instance, cardiogenic shock is a pump problem. It means a lot of times that the heart doesn't have enough oxygen, so because it doesn't have enough oxygen, it becomes hypoxic before any other part of the body does. Okay? And then everything else starts to fall to the wayside because the heart's like, I'm not working, nothing else is going to work either. Literally, that's what happens. Okay? CHF, like I said, increased heart rate and enlargement of the left ventricle don't make up for the decreased heart function. So cardiogenic shock can lead to congestive heart failure. Okay? What the heart muscle is going to do is it's going to swell in an effort to try to pump more. But it goes back to the old adage, not enough muscle is not good, too much muscle isn't good either. And so in this instance, with congestive heart failure and that larger left ventricle, too much muscle isn't a good thing. Okay? Your lungs become congested with fluid, and it's called serum. It's the fluid from the blood backs up into it and causes dependent edema. So depending on how you're sitting, that edema is going to fill the lungs. Okay? It's called congestive because they become filled with that fluid, pulmonary edema, It occurs suddenly, or it can happen over a period of time. Acute onset CHF, which is referred to as flash pulmonary edema. You'll see that again. Okay, flash pulmonary edema fills the lungs very quickly, and our treatment for that is what? CPAP, positive pressure ventilation. Yes. Okay. Used to be back in the day, we actually just bagged these patients, but now with the advent of CPAP, it's wonderful. We don't have to do that anymore. And like I said, CPAP is keeping people off the ventilator, doing what it's supposed to do. Okay. Hypertensive emergencies is anybody with a blood pressure over 180 systolic. Okay. That means the heart's working too hard. That's what it boils down to. They have a severe headache, and the possibility of having a stroke is very great. Okay? Very great possibility of a stroke, especially if it's untreated over a period of time. Some of the symptoms are altered mental status and pulmonary edema. Patients need to be transported very quickly and safely and easily, because any jostling around or anything like that can cause them to have a stroke. Okay? A AAA, or aortic aneurysm, is a weakness in the wall of the aorta. The reason this happens is uncontrolled hypertension. You have high blood pressure and you don't know about it. Okay? That's why this happens. A dissecting aneurysm occurs when the inner layers become separated. It forms what's called a berry aneurysm, or a balloon outside of the aorta. And what ends up happening is, over time, that balloon weakens. Unless they bleed out on that table, they're probably not going to make it. Okay? Unless they'll bleed out on the table. Unless it happens while they're on the table, they're probably not going to make it. Okay? And I hate that that's a fact, but that is absolutely a fact. Okay?
There's a lady that comes up to our station a good bit, and she's Hispanic.
Mm-hmm.
She always wants her blood pressure checked, and it's always through the roof.
Oh yeah.
Always. I mean,
no blood pressure meds?
Nope.
Or she's not compliant?
Nope. She won't go to the doctor.
Mm-hmm.
Nothing. And last time she come, because I've seen her probably 5 times, 6 times or so. And last time she come to us, and it was sky high like normal. I was like, look, if you do not get this in check, you're going to die from it.
Yeah. I've seen a 37-year-old have a stroke and die from a hemorrhagic stroke because he didn't take care of his blood pressure.
Yeah.
And like, it was the saddest thing I've ever seen. Like, we're walking this guy out, I'm bagging him because I'm getting ready to intubate him, and like, his kids are playing on the front porch, and they're like, "Bye, Daddy," completely oblivious to the fact that their dad is dying.
Wow.
Or was dead at that point.
Yeah.
We got him back, but it didn't do anything for him. What'd you say?
I said that's surprising.
Yeah, I mean, it's a thing. So what we're going to talk about is, let me go to. Okay, we're going to talk about cardiac monitoring. Okay, and I know EKGs are not an EMT skill, but placement of an EKG is. And where these electrodes go is an EMT skill. So when you're riding your clinicals or riding calls on the ambulance or on the fire truck, whatever, that is definitely something you could help out with. And some of the things that we do, it has to do with placement, making sure we have good skin contact to minimize artifacts so we can get a good EKG trace. Okay? You may need to shave them or do what we call manscaping. Rub the electrode site with alcohol so that way it sticks better. That's a great way to do it. Attach electrodes to EKG cables before placement. So don't ever put the sticker on and then try to snap it on somebody unless you have the clips, because that's just a bad idea. And then, of course, confirm your electrode placement. Take a look at your trace. Make sure everything looks good first. Then run your EKG. Okay? So this is your placement. Okay? You have on your right side, goes up here on the shoulder, not on the chest, goes up here on the shoulder, is your white electrode, okay? This is your right upper or right arm. Then your green is your right lower or right leg, okay? It goes right there just above the iliac crest or the hip. The black goes on the left arm, left upper arm, okay? And the red goes on the left lower abdomen just above the iliac crest, okay? clouds over grass, smoke over fire, right? Easy way to remember that.
I remember whenever it was 3.
Yeah.
Remember that?
Well, some people have
And,
3 leads, and what you'll see is black, white, red.
Yep. And then
Okay.
the paramedic that originally taught me, she was like salt, pepper, hot sauce.
Yes.
That's how she taught it to me.
Yes.
In
I like-
Jasper, they use 4 and 12,
Yeah.
but
Yeah. And your 12 lead, which is actually only 10 stickers, okay? But they're what's called augmented limb leads, okay? We look at 12 different pictures, 10 different ways. Or 12 different ways we look at 10 actual pictures, okay? V1 goes on the 4th intercostal right along the sternum. So you feel for where that rib is. In between that rib is where you want to put it. You don't want to put it over the rib because you're going to get a lot of artifact.
right.
V2, same thing on the opposite side. And then 3, 4, 5, 6 coming around the side. 3, you're going to put on last. 4 goes in the 5th intercostal, okay, at the nipple line, the natural nipple line. The 5 goes 2 inches beyond that, still in that 5th intercostal. You're just going to follow it around. 6 is almost mid-axillary. It's just at the cusp of the arm where the arm meets the underarm. Okay? So that's the placement of those. And we're actually I'm gonna show y'all when we do some lab next class where that stuff goes. Okay? So once we put these electrodes on, okay, turn on your monitor, print a sample strip, take a look at it, see what you got, and then if it looks decent, then you can run your actual strip to see what's really going on with your patient. And the reason that we do this and we do a test strip is you don't want to look at it, it looked like a heart attack, and you call into the hospital, and comes out, you just had your lead going backwards. You know what I mean? Always print your test strip, look things over, and make sure. Even in an emergency, slow is smooth, smooth is fast. You know, take the time to look at it. It's not your emergency. I know that sounds horrible. It's true. It's not your emergency. Okay. Let's take a quick break.